Thank you. Thank you for the kind introduction. I mean, it's nice to be a part of this interesting program happening online. And also, I believe a lot of people are having breakout sessions and interacting with the team to make healthcare environmentally sustainable. So I'm going to share with you in the next 25 minutes about how Aravind, being one of the largest eye care providers in the globe, how we are trying to do a low carbon eye care. And next slide. And how we are in the race to zero. Next slide. So when we talk about sustainability and resilience in healthcare, you can keep clicking either. You can keep clicking. There are few. So there are several things which are controlled by reusable supplies, disposables, a lot of electricity used, and capital goods. You can keep clicking. Lighting and ventilation, and also related to travel of staff and patient, food services, which have certain regulations. Yeah, you can click the next slide. So we at Aravind see it as a systems issue, especially in healthcare. And we are going to share with you how we have resolved some of these systems issue, at least in this part of the world. Next slide. So Aravind started way back in 1976 with 11 beds, and now we have, yeah, you can click the next. 7 tertiary care centers, and we have, next slide, 7 secondary care centers. So these are services which do cataract and refer the specialty patients to the tertiary care centers. And the next slide. And we have several city centers and community centers, which mainly do outpatient work. Next slide. And then we have a network of 108 primary eye care centers or vision centers, which are really in semi-urban and rural area and providing an eye care to 30 to 40,000 people in that particular geographical zone. Next slide. So on an average, every day we see close to 16,000 outpatients. We do more than 2,000 surgeries, and we do a lot of outreach eye camps where we go to the field, screen them and bus them back to the base hospital for surgery. And being a high volume center, we do a lot of teaching and training. A lot of residence and fellowship programs are offered, and also training programs for training mid-level ophthalmic personnel, counselors, technicians, optometrists, and several other programs happen throughout the year. Next slide. So when we talk about the low carbon eye care, I want to put it into two buckets. One is the general aspects, which normally most of the organization practice. And I'll focus more on the service design, which we do back at home. Next slide. So I think in general, these are general practices wherever possible, we have infrastructure which offers green buildings, at least in all our new facilities, which happened in the last 10 years. We have, kind of architecturally designed green buildings. We have used energy efficient appliances and gadgets, and we have strongly looked at alternate source of energy. Now I'll show you what happens in Pondicherry and other facilities. And we also minimize travel and transport, not only of our staff, because all our staff in all the new facilities they are housed within the campus. They have a quarters wherein they can walk to the hospital. And we minimize the travel to the patients by doing outreach, by doing these vision centers, and also trying to make sure that we try to finish all the investigations and maybe procedure also on the same day. And we have a very strong consumable procurement so that we can minimize the effort and optimize the frequency. And because we have our own manufacturing facility, we have a very good supply chain. And whenever there is a need, we get the supplies from our manufacturing facility at Madurai. a lot of importance is given to equipment maintenance. So we try to do preventive maintenance so that breakdown doesn't happen, and also the life of the equipment extends. And we also offer a lot of training around this for people with engineering background to maintain ophthalmic equipments. And not but not the least, about water and food, I'll also cover a little bit on this. Next slide. So can you click again? So this video keeps moving. Yeah. So what you see is the facility in Pondicherry, which is in the east coast of India. This is our facility, which is roughly 200,000 square feet. And if you see, the rooftop is totally covered with solar panels. Now, because we have a nice sun all through the year, so almost 60 to 65% of our electrical needs is generated locally from the solar plant. So we only buy 25 or 30% from outside. And also we usually buy clean energy. Next slide. Next slide. So most of our facility, like I said, from Pondicherry and all the new hospitals in Chennai, Tirupati, and the newer facility which is coming up. So we try to do green buildings where we leverage natural ventilation and lighting, like how you see. And the orientation is also to a great extent so that you minimize the solar heat getting into the facility. And the layout also is designed in such a way that the movement is also minimized. Like even the staff are housed inside, the paramedical staff, most of them stay inside in a hostel facility. The residents and fellows have hostel facility within the campus, so most of them walk to the hospital. And all this helps us to minimize the maintenance with the right choice of materials. Like if you see this facility in Chennai, if you see, the lights are only on the side where it is little bit dark. Now where you have a lot of sun entering, the most of the lights are even switched off in the daytime. Next slide. So this is just showing you the way we have at least done solar across all our hospitals. Next slide. So the Pondicherry almost generates 60%, but overall in Aravind and also in our manufacturing facility, it meets almost 10% of our needs. And we are constantly working on increasing this capacity so that we can even go up to 30-40% in the near future. Next slide. Next slide. Can we move on, Ether? Yeah, next slide. So the other important thing is in all our old facilities and also the new facilities, we have moved towards energy efficient and appliances and gadgets. So they all are all the lights have been changed to LED lights. All the fans have been energy efficient fans, and even the equipments like chillers and air conditioned plants have now been changed to really energy efficient, so that we almost have a kind of 30 to even 50% reduction in the amount of energy consumed by some of these appliances. Sometimes this is so important that we need to really work on these gadgets so that you become really energy efficient at the end of the day. Next slide. So this is again just a picture showing the water recycling plant, which is there at Pondicherry, which is called the DWATS, the decentralized wastewater. And finally, the wastewater, which is which is recycled, comes to the pond, which is used for gardening and maintaining even some of the kitchen gardens which we have in the hospital. Next slide. Okay. Next slide. So the decentralized wastewater treatment plant almost kind of recycles 90% of the water we use in the facility. And this water is again used for garden, and also some of the water is also now plumbed back to the toilet for flushing purposes, so that we can optimally reuse. A lot of rainwater harvesting happens, and then we also engage our own staff and patients to kind of reduce the water consumption by having waterless urinals and also reduce water flow in the taps. And by this, we are able to maintain a beautiful garden in most of our hospitals, which again kind of improves the overall experience of people coming to the hospital. And also, this has won several best garden awards and stuff like that. Next slide. So from the general aspects, I think I'll quickly move on to the service design, which is the most important part of my talk, and how we are optimally reducing, reusing, and recycling a lot of things. Next slide. Next slide. So a lot of efforts happens towards reducing, like closing the loop, uh, like finishing off the investigations and the procedures if the patients are prepared on the same day. For example, if a patient needs a visual field testing or a scanning for the optic nerve, or if he needs a laser for his glaucoma or diabetic retinopathy, if the patient is prepared financially and also mentally, the procedure and the investigations are completed on the same day. There is no appointments given. And we have introduced electronic medical record across our system to reduce paper waste. And there is a very rationalized use of consumables, which is evidence based. And also, we have been uh, producing a lot of evidence, which has been now kind of globally recognized. And a lot of procedures have been standardized so that we can really reduce the amount of resources which we are using. And then when we go to reuse and multi-use, again, a lot of evidence-based practice happens, like eye drops are used till the end of the day, some at the end of the week, like in operating room, it's end of the day, in the outpatient department till the end of the day, end of the week. And very clear protocols are given for reuse and multi-use. And there is a very important way, we segregate lot of waste at source so that we can optimally recycle and also repurpose a few things in a different way. Next slide. So when we talk about any healthcare, even in eye care, there are several footprints related to access, diagnosis, treatment, and follow-up. We constantly look at the flow of patients. Wherever there is a leakage, we try to fill that leakage, and we try to reduce the waste which happens in whatever form it happens, waste of time or energy or efficiency. We constantly kind of loop that and make sure that we are bringing the highest efficiency into the system. Next slide. So this is just to show the assembly line process which happens in the outpatient department. From registration, somebody escorts, and then auto refraction is done. Then the optometrist do refraction, the pressure is checked, blood pressure. There is a preliminary workup done by doctors, then a final, and then they escorted either for counseling or medicine or glasses. So in all these processes, one person is doing one task. And because they do one task, they become really skillful in doing that particular job. And this helps us to kind of attain a good quality also. And by this way, we are optimally and effectively using a lot of these equipments which are used in diagnosis and treatment, which again reduces a lot of wastage. Next slide. So beyond eye hospitals, I was talking to you about how we reach the unreached. So this is one way we reach the unreached, by a form of vision centers. Can you play that video? I think it should move on a click. If not, you have to go back and then play the video. It's on the video you have to play. On the video. Yeah, thank you. So this is a vision center or a primary eye care center, which is a 600 square feet facility, which is in semi-urban rural area with a population of 30 to 40,000 people. We have two staff who are taking care. One is a person who is doing now the registration and fundus imaging. That person is called a technician, and the second person is an optometrist. So these two people run these clinics. They see 30 to 40 patients every day, they do registration, and then they check their blood pressure, blood sugar, and then they do refraction, they check the eye pressures, and at the end of all the investigations, everything is entered into the electronic medical record, and telemedicine happens. So one of our senior resident is there in the base hospital consulting these patients. So each of our hospitals run 15 to 20 vision centers. Like in Pondicherry, now we have 17 vision centers, and you can see the telemedicine happening. The prescription is signed by the doctor from the base hospital, the drug prescription and the medicine prescription. And so once the prescription is printed, and now they are counseled, and then they get the medication. They have a selection of lenses right there in the vision center, so they can choose their glasses and then get the glasses done in 24 hours. If it's a ready-made glass, they did immediately. So this is like a hub and spoke model. So 85% of care is given locally, like a foreign body or conjunctivitis and things like presbyopia, or people who need glasses is taken care. Only 15% are referred to the secondary and tertiary care center for further care. So by this way, we are significantly reducing the carbon footprint of patients' travel because they can be easily accessed for the care. Next slide. Then can you click on the video again here? Okay, so some of our vision centers are now AI powered. No, so we wanted to improve the quality of the diagnosis of posterior segment diseases, especially diabetic retinopathy and glaucoma. So now we have this fundus cameras. Now this is a company called Remedio. We have no financial interest, and it's an iPhone-based technology where fundus images, and then there is an offline AI. Where immediately you can generate reports within a matter of 30 to 40 seconds. You get a report to say whether it is a referable glaucoma or a referable diabetic retinopathy, or you can follow up in the vision center. So we have also kind of explored technology, now advanced technology, so that we can make better diagnosis, so that unnecessary patient travel can be reduced. And most of our vision centers are now powered by low-cost technology, which is validated, and also with artificial intelligence like this, especially for conditions in the back of the eye or the posterior segment diseases. Next slide. Yeah, we can go to the next slide. So this is just to show you a map of our vision center network of 108 centers. If you see, we are almost covering the state of Tamil Nadu and Pondicherry. So the idea is people with eye care needs should not travel beyond 15-20 kilometers, at least for the basic needs. Only for any surgery or procedure, they have to travel little longer distances. Next slide. So this is a work which we did during pandemic, just to see how during the wave 1 and wave 2, where we had the peak COVID, how some of our centers did. If you can see, the percentage of people going to primary vision centers are more than 75%, or almost 80% during the second wave. This is before even when we had the vaccine. Whereas the tertiary and secondary care centers were only seeing 40 to 50% or only 60%. So that shows that the accessibility of care was so important even during pandemic. And this significantly reduced their travel, because travel was such a big burden during pandemic because of e-passes, restrictions which happened between different states and districts back in India. So these vision centers did a lot of good work in taking care of at least their eye care in that particular region. Next slide. So this is just a map showing how they did well. No, the vision centers did really well during both the phase, the wave 1 and the wave 2, when compared to tertiary and secondary care centers. Next slide. Just click again, the video should run. Now, can you go back and click on the video again? Yeah. Okay, so this is another one which we regularly do for the last 40 years, but over a period of time, we have improved the way we do community outreach. So these are eye cams, wherein a small team goes in a van. They set up this eye cam in a small school or a community hall, And now we do again low cost. We use a lot low cost technology, and we also have electronic medical record. So the patients are registered, a preliminary workup is done, then the optometrists do refraction. You can see those makeshift cubicles, and then the intraocular pressure is checked for screening for glaucoma. And then this camera is called a Bosch fundus camera, which is again handheld. It's like a small gun, which is very easy and comfortable to take mydriatic fundus images. The images are Wi-Fi transferred to the laptop in front of the final physician who is sitting there, and then he gives his opinion either for cataract or glasses or any referral for eye conditions like glaucoma and diabetic retinopathy. If they have cataract, they are immediately bussed to the base hospital. So 40-50 patients come together in a bus, they have the surgery done, and then we drop them back after a couple of days, and after 30-40 days we go back to the campsite. So whereby these outreach significantly reduce again the travel related burden and the carbon footprint for many of these patients who need surgery in the form of cataract surgery, which is the most surgery done in eye care. Almost 90% of our procedures is cataract surgery. Next slide. So these are some of the things which we regularly do in our practice, and we incrementally improve. We have a lot of lean clinical protocols with evidence, standardized operating procedures, and most of that, as I said before, the process is designed to complete all the investigations on the same day. We get the specialty opinion, like a glaucoma opinion or a retina opinion, on the same day. And absolutely, there is no waiting period for surgery. I'm sure people in UK will be surprised when there is a long waiting list for cataract surgery, whereas when the patient comes here, the very next day they get operated. Now, if they are ready for surgery, they can get an admission, or they can go home and come as daycare, and then the follow-up is done in vision centers or city centers or in the base hospital, wherever it is close by. So we have a system which is very efficient, so that we can deal with a good number. For example, in Pondicherry, every day we do close to 300 cataract surgeries. Next slide. So a lot of things happens around the supplies. So that is where I think optimally we reduce and reuse a lot of things. So there is a stringent sterile protocols. A lot of sharing happens between supplies, and then we minimize the use of single-use instruments wherever possible. We try to reuse very carefully, and then a lot of waste segregation happens at the generation point. And overall, you can see all these three happening. Next slide. This is an interesting video which shows you how in the morning, when the staff is opening, so even the plastic and the paper is separated. Now, when they are opening the knives, the keratomes, the sutures, and the supplies which you need for the day, even the paper and the plastic is separated at source, so that they can optimally be recycled at the end of the day. So almost 85% of the waste is recycled, and only 15% which is biomedical waste, which you can see in the red buckets here, which goes to the biomedical waste disposal center. So the surgery dress and gown, at the end of the day, what happens? We wash them, launder them, and then we do a full cycle sterilization. The trays and pans also done at the end of the day. Surgical instruments, after every case, the instrument will go to a flash autoclave, where they quickly wash them, rinse them, and then do a flash cycle, and then they get the set back for surgery. At the end of the day, they go for a full cycle autoclaving. Surgical gloves, in between cases, we put antiseptic, and we change the gloves every 10th case. And then syringes, knives, blades, everything are disposed after every case into the biomedical waste. Same way, needles and blades, cotton swabs and gauze, and like the video you saw, the plastic and the paper, the packing materials, the booklets which come for the lenses and sutures are segregated at source, so that we can optimally recycle at the end of the day. Next slide. So this is a work we did some time back. It was actually a Fulbright fellow from US, Casey Thale, who by accidentally I met her in one of the conferences, and then we said, why don't we measure the cataract waste and compare between what happens Aravind and in some of the hospitals in US. And this we published a few years back to show that, next slide. one cataract surgery in US is equivalent to traveling 500 kilometers versus just 25 kilometers in Aravind. So the waste generated was 1/20th of the waste generated in US. So this was an interesting study, and a lot of media and other coverage happened following this publication. Next slide. Next slide. So this is just to show you some of the work which we have done. The carbon footprint of one phaco of US and UK is 20 times higher than Aravind at the same time. Next slide. Yeah. The endophthalmitis rate in Aravind is almost 3 to 4 times lesser than the average endophthalmitis reported in Europe and also in US. So our endophthalmitis rate is 2 in 10,000, whereas international standards have been almost 6 to 8 cases per 10,000. So the infection rates are less, the TARS and other allergic conditions are less, in spite of 20 times lesser waste which we generate here at Aravind. Next slide. Yeah. So this is just to show you a comparison. Now this picture is a very popular picture. A lot of people use this in their presentation. So on the left side, you can see one phaco case in, I think it is Mass Eye and Ear versus 100 phaco cases at Aravind Pondicherry. Next slide. So the main problem is all the waste which is generated for that one phaco case, from the drape to the cassettes to the tubings, the phaco material, the gown, everything goes into one particular bucket. No, that's the problem, because it's not segregated. So everything goes to landfill as kind of biomedical waste. Whereas here in these 100 cases, almost 85% is optimally recycled, and only 15% goes to either landfill or for incineration in the biomedical waste. Next slide. So this is just to show that by optimal segregation, we are also able to generate some money. It's not a big money, but it also helps us to employ some of the staff who are doing the recycle work, who are handing over to the vendor who takes all those recyclable items. So roughly around $200 to $300 every month we can make just by optimally segregating waste at source in the operating room. Next slide. Next slide. Next slide. Okay, so this is a study we did during COVID times, because in COVID time we also had some restrictions, so there was only one patient. Next slide. In the operating room, we were cleaning the room for every case. The patient was wearing a gown as per the standards which is happening in UK and US. And what we did was we compared in the group 1 patients done before the COVID lockdown and during the COVID phase, when we started operating again with all the revised protocols, and we found no difference. Next slide. So this particular work we just did to show that practically there is no difference at the end of the day, even when you are doing the Western protocols. Next slide. So the most important part for the low carbon eye care is leadership. There's a high level of commitment from our leaders to constantly look into the process and keep looking at alternative energy generation and also the systems and processes. And morely, we do a lot of engagement with our staff and also with our patients, identifying and implementing any opportunities which come on our way. A lot of audit happens, and then we rectify a lot of things depending on the audit reports. And building this as a part of organization's DNA, that has been a big challenge, but that really helps to think out of the box. Next slide. So this is a thing which happens every day in Aravind Pondicherry. The caregivers of our cataract patients, roughly around 150 paying patients who go for surgery, they come with caregivers. We engage them in a green tour. So one of the volunteers in the hospital, they take them on a green tour to show them how we do wastewater recycling, the DWATS plant, how much of solar energy we generate with our solar plant, the vermicompost plant, how the kitchen garden is maintained, how the uh, nursery is maintained. So this tour also helps to engage our patients or the customers who come for care. And also we teach them some of the things like how can they have their own kitchen garden or do a vermicompost or even do a small solar panel in their homes. So we engage them, and then we have some QR codes for them to take home some messages. If they want more details, we help them. So we have been a very strong advocacy with IAPB. IAPB is International Association of Prevention of Blindness. There is a climate action working group, and we have been leading a lot of these actions, the 10 key areas which you see here, which are very important, and we are supporting a lot of these activities and also collecting a lot of evidence to share with the larger audience. Next slide. And this is one website I would like you to go and see. It's called the isustain.org. So this is started by American Society for Cataract Refractive Surgery, and now ESCRS, which is the European Society for Cataract, and American Academy are part of it. And every other day, there are a lot of people joining. Now we have 35 different organizations who have joined, and they are taking this surgical facility pledge, which you see here. And a lot of excellent sustainability resources are available on this website, including a lot of evidences, which we have also done over the last many years. And we are doing a sustainability symposium regularly for the last couple of years. And we are also meeting the industry like Zeiss and Alcon and Johnson & Johnson to make sure that industry also start practicing sustainable practices. So we believe that when you do environmental sustainability, it always leads to triple one. Keep clicking, Ether. Yeah. Happy patients. And when you have more patients, you can lower cost and you can be friendly to the environment. Thank you.